Good afternoon, everyone. I'm thrilled to welcome you to our webinar today. The title is Supporting the Care of the Mother-Child Dyad in Substance Use Disorder Treatment. I am Karen Scott, President of the Foundation for Opioid Response Efforts. And first, I'll just go through a few of the logistics for the webinar this afternoon. So as always, our webinar is being recorded and will be available on our website shortly after the session ends. We will also make the presentation slides available for download on our website. We really look forward to a robust Q&A discussion after the presentations, and we ask you to use the Q&A button at the bottom of your Zoom screen to submit your questions. Please note that if you see a similar question, you can also use a thumbs up to upvote the question, and that will signal to us to try to prioritize the questions of most interest to the group. We're also going to be using the polling function today during the presentation. So when a poll pops up, please select your response and submit, and the responses will be discussed live by our presenters. Following the webinar, we will make some resources related to this topic available on our website, and that will include some of the Q&A discussion from today. Additionally, if there are resources that you would like to share with this community, please do send them to us at info@forefdn.org, and we will include those in our follow-up materials as well. And finally, there is a brief survey immediately following the webinar. Please take just a few extra seconds and provide us with feedback so that we can continue to plan and develop our webinar series in the coming months. So for those of you who are new to FORE, welcome. The Foundation for Opioid Response Efforts was founded in 2018 and is a private national grant-making foundation focused on the public health emergency of the opioid crisis. Our vision is to inspire and accelerate action to end the opioid crisis, and we do this through convening and supporting partners to advance patient-centered, evidence-based solutions. We focus on work that is patient-centered and supports patient professional education, payer and provider strategies, policy initiatives, and public awareness. We're also developing the foundation's work across three complementary activities. Our grant making and our latest set of grants were actually just announced this morning. You can find the announcement and our new grantees, all of our grantees on our website. Convenings, including advisory meetings where we focus on specific topics, and summaries of those meetings are also on our website. And then thirdly, developing the foundation's ability to serve as a resource to the broader community. These webinars are one example of that resource capacity. And we also have on our website a number of issue briefs and other materials that we want to make available to all of you. Throughout our work, a major theme is a focus on vulnerable and very high-risk populations. And today, of course, we are focusing on one of those populations in terms of pregnant and parenting women and their children. We know that pregnancy and postpartum period is a period of high risk for relapse and overdose for women with OUD. We know there's still limited access to medications for opioid use disorder during pregnancy. And given the high risk of relapse during the postpartum period, we know there's a need for ongoing supports during an extended postpartum period. At FORE, we're currently supporting 3 grants that are working on aspects of treatment and recovery services for pregnant and parenting women. Our University of North Carolina Horizons Program grant, the University of North Dakota School of Nursing grant, and a grant to Renewal House, which is a residential program for women based in Memphis, Tennessee. Our recently released issue brief on the continuum of treatment for pregnant and parenting women gives more information about these 3 programs and 4 grants, as well as more information about the needs and priorities for consideration for this population. And we encourage you to go to our website again, download our issue brief, and share that with your networks. So our presentation today really builds on and extends our focus on pregnant and parenting women and to their children, to include their families and how to develop healthy families. We're very thrilled to have our presenters today. Dr. Hendrée Jones, Professor and Executive Director at the UNC Chapel Hill Horizons Program. Dr. Yvette Horton, who's Assistant Professor and Director of Child Clinical Services in the Department of OBGYN at UNC Chapel Hill. Dr. Elizabeth Johnson, Clinical Assistant Professor and Director of Medical Services, UNC Chapel Hill, and Ms. Essence Hairston, Clinical Instructor and Program Manager for the UNC Horizons Wake County Program, and also in the Department of OBGYN at UNC Chapel Hill. Following their presentation, we will have commentary from Drs. Walker Harding and Dr. Turplin, and I will come back and formally introduce our commentators at that time. Right now, I'm very happy to turn the presentation over to Dr. Jones.
Thank you so much, Karen, for this amazing opportunity. It's so great to see over 373 people here that have joined us. And so I am just going to just set things up and then turn it over to my fabulous team. So with the time that we have available, we hope to cover 3 learning objectives. One is really defining what attachment means and giving an example or two about how we can help promote healthy maternal child attachment, and also making sure that we're looking through that lens of cultural responsive parenting practices. The second objective that we'll cover is ways of identifying trauma and how that really can shed insight into the mother-child dyad, and then what we can do to help mothers parent through that trauma. And then finally, we're going to be looking at ways to support the dyad during times of physical separation, and then giving some pointers about navigating successful reunification. Next slide.
Thank you, Hendrée. So just a quick something to say about UNC Horizons. So our mission is to provide world-class, empowering, and transformative interdisciplinary care to women and children. We offer a continuum of services. We also are doing research and training the future generation of providers in this field. Next slide. So, oh, go ahead, Andrea. Sorry. So before we start, we thought we would do a poll just to kind of see where we are with knowledge and people's comfort on this topic. So our first question is, I feel confident and competent to promote healthy maternal child attachment. So 0 is not at all the way up to 5, which is fully. So I'll give you all a moment to do that question.
Sorry, you're going to want to do introduce all 3 quickly.
Okay, sorry about that. Okay. Our second question is, I feel confident and competent to identify ways trauma affects the mother-child dyad, again, from not at all the way to fully. And the third and final question, I feel confident and competent to help support the dyad during physical separation. So I'll give you a moment to do those.
All right, should we keep moving? And or actually, Ken, can you share what the results were? Excellent.
Oh, this is great. So it looks like most people chose somewhat.
Excellent. So that's great. And we've got a nice range of sort of not at all to fully. So excellent. Well, hopefully through some of what we share today and then future discussions, we can get everybody to feeling on that number 5 fully.
Absolutely. Next slide, please.
I'd like to share with you a case summary. And as we navigate throughout the PowerPoint today, I want you to think about this throughout the slides, and at the end or closer to the end of the PowerPoint, we will revisit this case summary. A 29-year-old woman presented at her prenatal care appointment during early pregnancy. She received prenatal care, screenings to assess for substance use, and a referral to treatment. She entered residential services during her pregnancy along with her 3-year-old son. Patient had multiple sources of trauma, including sexual assault and interpersonal violence from her partner. Early in her treatment, the patient opted to leave services. During that time, there was a brief period in which she returned to use that led to Justice and Child Protective Services involvement. The patient then reconnected to treatment services. Next slide.
So, given that many of you said somewhat, I'm guessing that most of you have heard of the word attachment and maybe know something about it. You might have had a class about it. You might have had a lecture about it. But we want to really distill this down into something that's easy to understand for this brief webinar. And basically, an attachment, and the way we're referring to it today, is the relationship between a caregiver and a child, whether that child be an infant or an older child. And we see attachment relationships in all cultures. It's universal, but it's also influenced by different cultures' values and beliefs. We also know from 60 plus years of research that attachment, a healthy, or we could say secure, you may have heard that word also, attachment relationship is really beneficial to development to the child and later on in adult relationships. You can go to the next slide. You will also see in our title that we mentioned mother-child dyad. And at the UNC Horizons program, we are serving mothers and their children. So we will refer to mother and child a lot, but it could be any caregiver that has a close relationship with a child. And one thing you need to think about in terms of dyadic relationships is that it is reciprocal. If you think of a mother and an infant talking back and forth and babbling back and forth to each other, they are sharing their social interactions and their emotional interactions. And, you know, attachment can be healthy or unhealthy, just like in any relationship. But it really matters in terms of long-term development for the child, that attachment relationship be healthy. And we call that a secure attachment. And when I am looking at a mother and a child dyad who has just come into the residence, I'm looking and watching them interact, and I'm getting a picture of kind of the history of that relationship, of how each individual is responding to each other. You could go to the next slide. And I like to use this graphic to conceptualize attachment and dyadic relationships. I like to sometimes refer you to think about this as a couple, because if you think of couples therapy, you're thinking of each individual bringing something to the relationship. And it is the same in an attachment relationship, except it's a little skewed. The mother is bringing her entirety of her history to the relationship, and the child's bringing his or her temperament and any other factors about the child to the relationship. And we want to know, can they see each other? Can they emotionally hear each other? And can they meet each other's needs? You can go to the next slide.
So we're going to talk for a moment from the mother's perspective. And an important piece that we see here at Horizons is thinking about how trauma affects the mother-child dyad, and how can we can support that relationship going forward. So trauma is not just an event in isolation that happens. It is the experience of the individual, or if you have a mother-child dyad, the individuals together experience, and then the long-term effects that event and experience can have on a person. Next slide. So we know there are numerous studies that have been done looking at trauma amongst women who use substances, and we know that the rates are higher than in the general population. We at Horizons collect data on an annual basis, and this is just a snippet of the traumas that a lot of our women have reported, and they report this when they are first coming in to see us. So we know that this is oftentimes a little bit of an underreport. And many of our moms report more than one of these traumas. So being homeless, emotional abuse, physical abuse, sexual abuse or assault, domestic violence, or sex work or trafficking. Next slide. So we know that this can greatly impact how moms interact with their babies. Moms with substance use histories report oftentimes more often that their babies are irritable. They may seem a little less sensitive to interactions with their children. Sometimes people will describe moms as looking a little flat in their affect. They may appear less emotionally engaged. I've had moms say, you know, I know I'm supposed to love this baby, but I just don't feel it yet. They may be less attentive, and there are potential risks for an increased risk for child maltreatment reports. So next slide. So we know that there are biological reasons that this is happening. So this is an older slide from 2004, but it's looking at the amount of dopamine that's available in brains. And so on the left side, you have control subjects, and on the right side, you have different substances of use. And you will see that from cocaine to methamphetamine, heroin, and alcohol, the amounts of dopamine that mom has available to her. So that's going to greatly impact her ability to feel good feelings and to feel attachment with her baby. Getting to the bottom line that we know substance use is a brain disease, and that does impact how moms are able to parent. Next slide.
And Elizabeth, just to point out something that I think one of the things that we've seen at Horizons is, regardless of whether or not we talk about the risk factors, for which there are many, there are also incredible strengths that our women bring. And I think every single woman that's ever walked through Horizons has an amazing capacity for love for their children, and they're there because they want the best for themselves and for their children.
Absolutely, absolutely.
Great. So thank you, Elizabeth, for kind of describing what the mother is potentially bringing to the relationship when they come into treatment at UNC Horizons. And now we have the child side of the dyad and what the child may or may not be bringing to the relationship. We know that children who have a history of familial substance use and often bring other risk factors, whether they were prenatally exposed to various teratogens, or they have a history of child maltreatment, or some behavioral symptoms or mood symptoms. You can go to the next slide. So here's an example of a typical year that was randomly chosen that describes the children in our program that arrived in our program. We take children from birth up to the age of 11 and pregnant women, so even pre-birth. And this is just a sample of some of the risk factors that they were arriving with. And one of the things that we do with all the children is assess their trauma history. And in this particular slide, I'm showing you what we found with the traumatic events stress screening. I can't talk today. Screening inventory, the parent report. And you can see that the children are arriving with between 0 and 13 different, you could call them adverse experiences or potentially traumatic events. Next slide. So now what do we do? So we have a mother with risk factors, a child with risk factors, and as Hendrée presented, both the mother and the child have resiliency factors that we haven't even mentioned, and they have arrived at UNC Horizons. And so now what do we do? And one of the things that we believe at UNC Horizons is that you support the relationship while concurrently treating the mother and the child for any medical or mental health issues that they have. And so this slide is sort of a little bit of a takeoff on Circle of Security Parenting, which we use at UNC Horizons, and that we as a community at UNC Horizons and as a society, I believe, need to support this very important attachment relationship. And next slide.
So here's our next polling question. And so I'll read it and you can open up the poll. So it says, in my community, women can easily access substance use disorder treatment. No, yes, or I don't know. And then in my community, we have enough spaces and places for women to bring their children with them during substance use disorder treatment. So the polling should have popped up and you can enter your answers. And then Ken, I'll let you use your discretion to when to close it and when to show our answers.
Sounds good. We're about 60% there.
Okay. All right. So it looks like, thank you so much for taking the time to answer the poll. So it looks like for both questions about women being easily able to access substance use disorder treatment, 45% of you said no, 41% said yes. So I think that's probably better than what I would have imagined. And then the second question, the vast majority, 75% said no, that we don't have enough spaces and places for women to bring their children with them to substance use disorder treatment. And I mean, that is something that has definitely been our experience. We continue to have a waiting pool, and I can't tell you how many women talk about making that gut-wrenching decision of, are they going to, you know, not get the treatment that they really want and need and continue to parent, or do they have to find a place for their children to live while they go and get the treatment that they need? And that's just a gut-wrenching decision that no one should have to make. You should have the ability, being any type of parent, to get treatment and to also parent. Thanks.
Next slide. So now, what do we do? How do we do it? How do we as a society, and we can tell you how as a program we support the attachment relationship between a mother and a child. At Horizons, I think it was mentioned, but we have the mother and the child, or mother and children, for 9 months potentially. So there is a lot that can be done in that 9 months to really support and strengthen that healthy attachment relationship. Next slide.
So we're going to talk for a moment what we can do to support the mother-child dyads during the prenatal period, because attachment starts when mom is pregnant. So it's real important that that all pregnant people are verbally screened for substance use disorders, and then that we have resources available if a referral is needed. It's incredibly important that we promote a trauma-informed or trauma-responsive approach to prenatal care. In the clinic that I have at UNC Horizons, this means that everyone, from the person who checks the patient in all the way up to the provider, everyone knows about the prevalence of trauma. We are taking steps to be sure that we are making mom feel safe and feel welcomed in the clinic. And there's multiple things that there, at times when I list it off, it sounds really simple, but I think altogether it's just such an important thing, because we know that birth outcomes are so much better when mom attends prenatal care appointments. We want to be sure that every pregnant individual, including those who are incarcerated, have adequate and quality health care. It's important to refer for case management, to address issues related to housing, food insecurity, transportation, etc. It's also incredibly important that women have the ability to have support from people who they culturally resonate with. There are multiple resources out there. There are doulas,
There are lots of support people who can help mom through the prenatal care and birth process. And then I can't stress this enough, we have to remember in the same way that when you work in the hospital, discharge planning happens at the time of admission, we need to think that postpartum planning really starts at the first OB appointment. So that's helping mom think through, does she want contraception to be able to space her pregnancies out? Does she have a safe space to go with the baby? Like all of these different things we need to be helping her think about at her first appointment. Next slide.
Just to jump in, Elizabeth, just one
Yeah.
of the things that we found to be really helpful is having peer support specialists or recovery coaches be a part of our treatment team, both in Elizabeth's clinic that she runs and the residential services that we offer, because it's so nice to have that experience of people that have been through perhaps the system to be able to guide women and help them feel more comfortable and also more trustworthy of us as additional providers.
Yes, thank you, Hendrée.
How can we support dyads during infancy? We want to empower and normalize breastfeeding for all patients, including those who are incarcerated. And we want to teach new parents strategies to help console their newborn and promote sleep and bonding. We also want to provide education about the period of purple crying, emphasize that substance use and separation due to incarceration are not primary causes. I've worked with a couple of women who reported that purple crying phase, which is a normal phase for babies to just cry and strengthen those lungs, and a lot of shame and guilt for women who are impacted by both substance use and incarceration, a lot of guilt and shame around that. We want to talk about the hormonal changes that may lead to postpartum anxiety and depression that may interfere with bonding. And we want to integrate community-centered and family-centered approaches. So going back to what Elizabeth shared earlier about cultural humility and making sure that values are a part of the plan as we're supporting families. And we also want to refer dyads to infant mental health providers trained in evidence-based practices.
Hey, Yvette, could you just define purple crying for us?
Sure. So around 6 to 8 weeks, all infants go through a maturation kind of process and have increased crying for a few weeks. And it's very normal, but if you do not educate the caregivers, they can think that they are doing something wrong or that something is wrong with the baby. So we really at Horizons teach every mother of an infant about this increased period of crying and how it normalizes and goes back down after a few weeks. And they are always so appreciative to know that it's not something that they are doing wrong, because they almost always think they're doing something wrong.
Mm-hmm.
And purple is an acronym that helps describe what that crying period is like. So it's easy to look what those pieces are. Yeah, go ahead, Essence.
Thank you. How can we support dyads during tough times? We want to empower and support mothers when calls to CPS or Child Protective Services, child welfare services need to be made. It's really important to make sure that parents, women are a part of those calls. It's when they need to happen. When appropriate, help advocate for additional support rather than child separation. So what we all know is that mothers thrive with their children, babies thrive with their mothers. And so we want to support that as much as possible. When child separation has to occur, we want to encourage phone calls, letter writing to offer connection and provide updates, especially for women who are currently incarcerated, whether in jail or prison. And also when separation occurs, we want to allow fictive kin, communal supports, and other cultural influences to be a part of that treatment plan. So again, looking at it from a holistic, individualized plan that meets the needs of the dyad. Next slide. Oh,
If I could just jump in too. So just, I think one of the things that the team does really well is working with Child Protective Services and helping empower mom to give positive updates. Hey, my baby just learned to crawl. My baby just learned to stand up. My baby just learned to walk. These are the positive things that I'm doing as a parent. These are the positive changes that I'm seeing, so that CPS gets a really complete picture and not just the negative things.
Absolutely. So how can we support Dyad specifically related when mothers are incarcerated? And we want to do the same thing that we would do for when women are not incarcerated. So empower so that they can be a part of the placement process during and post incarceration. Again, we want to allow fictive kin and communal supports to be a part of that treatment plan. So if CPS or child welfare services, they have to be called. What can we do to maintain those values and morals of that family, of that dyad? And we want to encourage phone calls, letter writing to offer a connection. We want to provide updates, offer ways to ensure breastfeeding. I know that North Carolina is moving towards navigating how to make that happen to strengthen that connection, because just because moms are incarcerated, it doesn't mean they're no longer moms. And so it's really important to honor that title. We also want to ensure that housing, treatment, access to medication, assisted treatment exists for those transitioning from prison, so that reunification can occur. So thinking about those Maslow hierarchy of needs. So for this family, this dyad to thrive, they gotta have that foundation. And so it's so important. You also want to provide intensive behavioral health supports post-delivery and post-release. As soon as someone, is released from prison, you want to be there in the car. You want to make sure that dyad is connected. That is such a vulnerable time for a pregnant woman transitioning, especially if your state is not equipped to administer Suboxone, Subutex, naltrexone, etc. With MAT post-release, is really important that next day or that same day that someone is able to access that. You also want to be aware of local and state legal advocates who can help promote treatment instead of incarceration. So what we want to also highlight is that substance use during pregnancy, we don't want to criminalize that. We know that incarceration is not an intervention. It does not reduce any opioid-related deaths or injuries, or promote recovery. And so at all costs, we definitely want to make sure that we're addressing perinatal substance use impacted by incarceration as well. Next slide.
So what are other ways that we can help support that dyad, and thinking about looking at things through a cultural responsive lens? And so I encourage everybody to walk around where you work, where you interact with people. And I know it might be virtual now because we're all on Zoom, but when you get back to your office, what are the messages that you have on the walls? Who is on the walls? What do your walls say? What do your treatment materials say? What are the pictures that are there? What are the words that are used? Using first person language of recovery is incredibly important, because it seems that oftentimes we use so many stigmatizing words, and we need to reverse that. And who is there, and is it representing everybody that is walking through your clinic, and are you making people feel safe and supported? Also asking families what they need. How can we be more culturally responsive to you? These families know best. They are the experts of their lives, and it is us that have the privilege and honor of being there to kind of, as I say, in the sidecar as they navigate their journey of recovery. So what can we do to make things better? How can we be more culturally humble? being open to parents' particular parenting approaches. You know, we were all parented in a particular way, but it doesn't mean it's the only way. And so really trying to understand, being open, asking questions, and then also kindly and compassionately maybe challenging some of those things only in terms of, are the practices that you're using now helping you get the results that you want to see in your children, and helping them understand the difference between, you know, punishment versus discipline, and being able to help them embrace their cultural activities and also embrace the best parenting practices that are going to work for them to get the children's behavior that they want to really see be optimal. Next slide.
So here's the ending of our brief case summary. So now that patient has several years of recovery, her children are doing well, and she continues with dyadic therapy. She has maintained engagement with psychiatry and behavioral health services, and she has met numerous physical health goals. Next slide.
So now we're going to end with our final poll to keep everybody engaged. And so this is a bit of a long one. We'd like you to, or would you like to participate in a collaborative peer consultation on the topic of dyadic care for pregnant and parenting people with substance use disorder? So the idea would be that we would come together either in a group, small groups, or maybe even in a large group, to provide each other with an exchange of ideas and knowledge and practices, and be supports to each other, because this work can be incredibly lonely and frustrating and isolating. So that's the first question. Yes, no. And then the next question is going to be, if you said yes, or even if you said no, what topics would you want to learn more about? And there are 10 different topics that we could think about. So topics from today: medication to treat opioid use disorder during all 4 trimesters, and dyadic neonatal opioid withdrawal and neonatal abstinence syndrome support, developing and implementing plans of safe care, navigating privacy and confidentiality for patients in an ever-changing environment, building a resource network to support the mother-child dyad, building or help healing mothers building brains using a dyadic mother-baby play in substance use disorder treatment, infant mental health, like what is it and how do we promote it, early childhood mental health, a focus on dads, and finally then building and maintaining collaborative relationships with child protective services. So we are going to give you a moment to answer all those questions. And Ken, again, I will leave it to your discretion as to when to close the poll and show us those results.
We'll leave it up for a minute since this one's a little bit longer.
It's a lot. And we really hope, as you're filling out this, that this is the start of a really engaging and rich conversation where we can all learn from each other and bring in different ideas, different cultural perspectives. There's so much variation in states and how they do things. And yet I know we all have the same common ground, which is wanting to help promote parents and children's relationships. And I was seeing in the chat box, there looks like there's some enthusiasm, so that's great.
We're about 60% there. I'm just going to give it another 30 seconds to let people have a chance.
No worries. And as we wait, is there any kind of final comments, Essence or Yvette or Elizabeth, that you all wanted to make?
I really liked your earlier comment, because I think that sometimes we forget how much, I mean, our moms love their babies so much, and so much want to be successful. And it's a beautiful thing to watch unfold over the time that we get to be with them.
Mm-hmm. Thank you. Oh, here we go. All right. So 76% of you said, yes, you want more of this. This is fantastic. Thank you to the 189 people. And then different topics, it looks like, wow, 59% of you want developing and implementing plans of safe care. 52% medication to treat opioid use disorder during all 4 of those trimesters, and then Dyad withdrawal support, 58% building resource network, healing mothers, building brains as 58%, great. And infant mental health, 54%, early childhood mental health, 51%, focus on fathers, 56%. I think we don't talk about that enough, so that's really exciting that people want to have that engaging conversation. And then building relationships with Child Protective Services, wonderful. So there's a lot of interest in a variety of different topics. So thank you so much for taking that time. Next slide.
Great. Hendrée, UNC team, thank you so much. Such a rich discussion, and really exciting to see how much interest there is in us continuing it. I'm really thrilled now and so appreciative that we are now joined by Dr. Leslie Walker-Harding, who's Senior Vice President and Chief Academic Officer for Seattle Children's Hospital and Chair of the Department of Pediatrics at University of Washington, and Dr. Mishka Terplin, who's Senior Physician Research Scientist at the Friends Research Institute and a member of the FORE Scientific Advisory Council. I'm going to turn to Leslie first and then Mishka for a few comments on the presentation.
Well, thank you. Thank you very much for all your work that you're doing for families and children in North Carolina. I think this was a very informative presentation, and I really loved your human touch to it with the case, just showing us these are people and that, we need to care about and not just, a symptom or a number. So thank you so much. I'm honored to be here today to reflect on some of your work and contributions to this field. As a pediatrician and adolescent medicine specialist who spent most of my career treating and preventing substance use in adolescents and young adults, addressing substance use disorder and the mother and child dyad and attachment and thriving is of critical importance for everything that we do all across the life course. And the efforts to preserve and or repair the mother-child dyad relationship and attachment and families is critical for all of our children, but it's even more so for the mother-child dyad when the mother is dealing with a substance use disorder. So thank you for highlighting that. Immediately after birth, a child, an infant of a mother who has a substance use disorder is at risk for neonatal abstinence syndrome, or more specifically, neonatal opioid withdrawal syndrome if it's opioid disorder. And they spend extra time in the hospital, possibly have more medical care. That's just the first hurdle that the family has to address and the child has to address. So you touched on this. I think it's important to consider the adverse child experiences with every child, but a mother who has a substance use disorder starts the child out. The child already has one prenatally. And without intervention and lack of attachment, this is profound throughout the rest of their adulthood. And for those of you who haven't spent as much time in pediatrics and hearing about adverse child experiences, 4 or more ACEs, as we call them, can result in chronic illness like more cancer, more diabetes, and more mental health issues later on in adulthood. So it's something that we're all focused on and trying to prevent and mitigate and help people who have had those so that those things don't happen. If substance use occurred in isolation, it would represent one ACE, but we know, as you mentioned, some of the other adverse child experiences are trauma, abuse, history of violence experienced by the mother, incarceration, mental health concerns. You touched kind of around it, institutional and personal racism, separation, food insecurity. All of these things are much more likely in a family that has substance use disorder in it. So, we know that we need to proactively support and advocate for these moms and their families before and after birth. And understanding the mom's, protective factors or resilience or positive supports. And you touched on some of the agencies and community services that might be needed to support them is important. And prevention of dyad separation, delivery of trauma-informed care, which, clearly for many women, I actually think that we should probably have all prenatal care and a lot of care just being trauma-informed, because we never know the level. It's so high in our communities. Eliminating bias and racism in the care and approach are all essential. But I think, taking the steps outlined today support the mother-child dyad, and can possibly break that cycle of historic, personal, institutional trauma that we cause, that they come with. And one of the things I think I wanted to just highlight is, advocating for all states to maintain and cover maternal insurance with the state insurance vehicles for at least a year is critical. I know a number of states are trying to move that way, but having 60 days of care is really not enough, especially when you're dealing with a substance use disorder. So it's I hope that is something that we can think about. And advocating for treatment, as you mentioned, instead of incarceration, that is critical. And then maybe that'll lessen the separation that these parents feel from their children. And even the other thing that came up when you were talking, I was thinking about, just treatment for women, treatment for adolescent girls. The treatment modes that we have, many of them were developed for men. And so, having more of those treatments that are really geared toward females and, the female gender, transgender and cisgender would be really nice, and probably be much more helpful for the children. So just overall, I'd love to thank Ms. Hairston and Drs. Jones, Horton, and Johnson for really highlighting, actually doing something and following and seeing the results, and really, giving us a call to action in other areas to try to address what your program, and really supporting the dyads as well as you have. So thank you.
Leslie, thank you so much. Let me turn it to Dr. Terplin.
Well, thank you. Thank you all of you for this, really for the work you do, and for how you've built this program, I believe, centered on the dyad and attentive to the people that you care for. And thank you, Karen and FORE, for inviting me. And I have some notes, and what I want to kind of do is problematize some of the assumptions in this field, and in paying attention to how we talk about things. And really, I want to begin with the word vulnerable. Like, what does it mean to be vulnerable? And I would argue that people aren't vulnerable, that people are made vulnerable, by socio-political forces. And that vulnerability really occurs in this gap between, those with the power to define others and to actually delineate people's needs, and those who are actually being defined and usually, being dismissed. And we see this in your slide where you look at the trauma slide, and the proportionality of different sorts of trauma. And I'm going to set aside homelessness. And I do think we need to think about that actually as a form of violence. But all of the other traumas are all based on gender-based violence. And we call them a bunch of different kinds of things. And by calling them these other things, we aren't naming what it is. And we aren't necessarily identifying, how to, speak to structure. And to me, this illustrates a tension in the field. We've had increased attention to what we call social determinants of health, and that's what we do at the clinical level. But there's that's not the same thing as addressing structural determinants of health. In fact, by talking about and focusing on the social determinants of health, we continue, the inequitable structures from which those social determinants emerge. And we see this in your data, in particular around child welfare and incarceration. So yes, I agree we should screen people for substance use disorder. But I am aware that the consequence of that screen, can lead, to a child welfare notification, can lead to a cascade of events that leads to child removal, causing, arguably a far worse adverse childhood experience than, and leaving aside the conversation about developmental outcomes, et cetera, to substance use exposure. And so what happens in that example is, by being attentive to a social determinant, we are perpetuating a structural inequity. And I think we, kind of, need to take a step back from that. And then thinking, the second word I wanted to kind of focus on is this word risk. So what does it mean to be at risk for poor nutrition, trauma, or to be at risk for violence? What does that really mean? Is this an individual level pathology, which is what happens? Or is it a way of sort of offsetting the structure and the social responsibility to the individual level? And thereby, so all of this, and you guys do this. And this, what I'm going to say comes, like a simplified version of a reproductive justice, framework, like Loretta Scott and Monica Simpson and other Black feminists, but that all mothers require a range of supports. And these include economic supports, right? Things like living wages. People need to be able to plan and time their motherhood such that childcare is possible, and people need to have the ability to mother free from interpersonal and other types of violence. So how many, of these, what we call risk factors, flow actually from the lack of support that, for the rights, the human right of motherhood. And, there's this tension, I think, when we focus on we talk about choice, and that's our cultural ideology of individuals. But in, the example from one of the polls, it was quite clear that access is grossly insufficient. So it's not, we sometimes reframe risk around choice when it's really an issue of access and structure and society. And so this lack of support that exists in general, really renders choice all but impossible. And what that does is, really deny dignity to people who are mothers and people who are parents and people who are pregnant. And underlying this is this assumption that some people don't deserve support. And we see this in the space around pregnancy and substance use. So I really, really liked your definition of the dyad and the way it was, linked and operationalized to attachment. And I liked how you talked about, this, when you talk, not just the culturally responsive lens, and not just sort of, and kind of trying to look at your space centered through the eyes of the people that you care for, but in addition to involve them and their voices in how to make your work more meaningful and more welcoming. And in this, I really think that what you're doing to some extent is really addressing, kind of what I started with this falsehood around, the words risk and vulnerability. And there's this term in philosophy that I just stumbled over, and it's called epistemic injustice. And it's this idea that it's a condition that that people, it's like the dismissal of people's knowledge and experience. It's an erasure, it's a silencing. And it happens in particular with people who are, labeled as vulnerable. And what you're doing by including, what you were talking about, Hendrée, really is a way to resist, that epistemic injustice. And so keeping that at the center and growing from there from what you do. And with that, I'm over time. I apologize. Thank you.
Misha, thank you. That was terrific, very provocative, and I don't think anybody minds if you do go over time a bit. Really, really so helpful and valuable. And Leslie, thank you so much as well. Getting the perspectives of from both of you really helps add greatly to our discussion. We have a lot of activity and a lot of questions, so I'm going to see if we can get through a few of these. And just to note for our audience, we did extend this this session to go until 4:15 because we were anticipating a lot of questions and dialogue. So I do hope you can stay with us and hear some of the responses to the questions. Hendrée, I think I will start on some of these with you, and then you can determine others on the UNC team who you might want to help in providing the response. We had a number of people ask about verbal screening tools that you use for pregnant women during the prenatal period. Are there specific screening tools that you'd want to highlight? This back in reference to identifying trauma risk factors.
Always have to unmute. So I would just want to build on what Mishka said in terms of verbal screening. And, when we think about, I think about screening as a way to have a conversation. And I know Mishka and I have talked a lot about it's like just like a urine drug test. What do you do with that? Like why? The why needs to be there. Why are you doing it? And if you don't have a good response for it, then you shouldn't be doing it. So for us, we use verbal screening as a way to engage, as a way to have a conversation. And it's not even so much about the validated tools, of which there are many, and Grace Chang and her colleagues and others, Kim Yonkers and others have got wonderful validated tools out there. And some are integrated with other issues that pregnant people might be facing, like depression, anxiety, and other issues. So again, I just want to emphasize the point of it's a way to have a conversation, and then the response that you make needs to be kind, it needs to be compassionate, and it needs to be supportive. And I'll let Elizabeth add anything else to that she wants to.
Thank you, Hendrée. The only thing that I would really add is I agree with Mishka. It's incredibly important to be aware of the context in which you practice. I know that where we are is not the same as every place else, and the information can often be used to harm mom and to harm the dyad. And so it's really important that you be aware of that and the context in which you're asking.
If, just to add one more thing, if people are looking for validated tools, the SAMHSA clinical guidance around pregnant people for opioid use disorders and their children has a nice summary of that. And there's some recent publications that compared the different tools head to head. And basically they found that there is no one great tool, that different tools work better for different people.
Great, thank you, Hendrée. Thank you. Following on perhaps on Elizabeth's comments, there are a number of questions about about calling Child Protective Services. What conditions, what circumstances prompt you to call CPS?
Elizabeth, Yvette, do you want to talk about that?
I can. Are you referring to women when they're pregnant or after the baby's born?
The question is not specific, so I'll leave it to you on any aspect of the question.
Well, obviously, if you're going to be treating the mother and the child together, you have to make sure that everyone can be safe. And in the law doesn't mention much, Elizabeth, correct me if I'm wrong, that if you're pregnant and using that we need to make a report. The reason I asked is I thought I saw a question specifically for that. So I wanted to make sure I wasn't.
Oh,
thinking
there
about
could be another one.
Yeah, I think that's an important distinction. And again, that really speaks to having to know what the law is in your
right in your state.
In North Carolina, we are fortunate that it is not a crime. Like, that's not considered a reason to either incarcerate mom or do any other interventions if mom is using during pregnancy. I know there have been laws in other states where they have tried to criminalize use during pregnancy. Those have been found to not have good outcomes because they prevent mom from accessing care.
Thank you.
Does that answer the question you want me to add to it from once the child is born? I'm happy to.
And then you add, yeah, I think what people would like to hear about both sides.
Okay. When a Dyad comes into our residence, we provide all kinds of support, therapy, case management, people on site 24/7 to assist the family. But there are times when mom's disease is so severe that she can't stop and can't parent at the same time as work on her recovery. That's rare, I would say. I mean, most of our families that come in and get the support they need for their recovery do well, but occasionally we will find a mother who will relapse or has comorbid medical or other mental health issues that are interfering with her ability to parent. And so we might have to kind of work on what is the best way to treat this mom. And sometimes that does mean that the child will need to go perhaps in kinship care for a while while we work on all these other issues with the mother, but that doesn't necessarily have to impact the attachment or the dyadic relationship. And we usually use our mother, child, infant mental health interventions to help talk through this process, to help talk through that mom has a sickness. And right now the sickness needs extra support, but that doesn't mean that she doesn't love you. So we do this in many, many different ways. But sometimes we do have to, as we are all mandated reporters, have to make a report if we just think the moms cannot function right now as a parent. But that's not to condemn the parent, it's just that we need to do something different to get that dyad support. I hope that helps.
Thank you, Yvette. Yes, I think so. Any other comments on that, Essence?
Yeah, I would also like to add that as we are all mandated reporters, we're also responsible to make sure we're giving clinical recommendations too and being that advocate for mom. So both things can happen and occur at the same time. When I have to make these calls or in the calls in the past, mom is present with me and mom is never blindsided. I'm oftentimes talking it through with mom. So empowering mom to actually make that call and talk it through. And then we work together on a plan. And so I will say, and Yvette, Elizabeth, Andre, correct me if I'm wrong, we typically look at abuse and neglect and certain things that fall under that. But anytime that we call, we are also making sure that we're providing other recommendations, other resources. So again, that family can still thrive. So I just wanted to just put that out there.
Thank you.
Yeah, this is Leslie. I had one thing I just wanted to bring up with this because there's so much bias in who gets called CPS, and that word safety is a word that needs to be deconstructed. What constitutes safe for one person and for the perspective of the provider may be completely different from what truly is safe for a patient, and it results in a lot of people being penalized, for when they need support. Being penalized, being misinterpreted. And I think it's really important if all of us are, because there are times that you must, a child is in danger and there isn't anybody else, and you just, you need to help that child stay alive. But there are many other gray areas where the word safety has been used almost, like a weapon, and people have been damaged, and their families have been damaged for, a generation from that. So I just think it's important to bring that up if we talk about CPS and calling.
Could be one of the most challenging areas, and certainly a lot of related questions on here. And I think, Hendrée, we may want to think about how we continue to respond and flesh out a set of issues, responses around these issues. I do want to get to a couple of more questions. Hendrée, there are questions about what the Horizons facilities look like for the parent and children, including how you handle school for the kiddos. And
oh, school during the pandemic is nothing like it. Yeah, Yvette, do you want to talk about that? It's been an odyssey.
Sure. It's been quite creative during the pandemic, for sure, as we've all been remote learning here in our particular area of North Carolina. Our residence is assigned to one of the local elementary schools in our area, and we have a really collaborative relationship with our elementary school. We work with the school social worker, school counselor. We work, help getting our kids IEPs if they need extra academic assistance. So we're very fortunate that we have a good collaborative relationship with this one particular school. So all of where our school-age children live is into this one particular school. So it makes for a nice long-term relationship.
And then the other thing that we did is while they were going to school completely virtually, we created our own little mini old style classroom where we had several grades in one very large socially distanced area and some supporters of the children to help them navigate the online system and stay engaged. So that we are very incredibly fortunate to have donors that supported that service for them.
Definitely. Because the mothers, you realize, in our program are concurrently getting their treatments. While the children are in school, whatever form that takes during a pandemic, the mothers are also getting their treatment. And so we want the moms to really be able to focus on getting as much as they can out of their dose of treatment. And so this allowed that. In theory, we're going back a couple days a week in the next week or two. So we'll see how that works.
An ever-changing response to that question right now, but thank you. Actually, the last part of that question was about dads. Are there ways that you engage and incorporate fathers into the programs?
Yeah, absolutely. So obviously for our residents, all of our potential visitors are going to be screened to make sure that there isn't active domestic violence that's going on, but we definitely want to support that relationship and including grandparent relationships or whoever the woman calls family for her. So there's a lot of times when they're coming for visitation. I know Yvette can speak to working with dads around the parenting practices. So they even come to prenatal care appointments. It's very common to see a very anxious dad sitting in our waiting room. And so that's really lovely. So I'll let Yvette answer more.
Sure. I have done a lot of work with any caregiver who is safe and available for that child, because we know from the resiliency research that the more safe caregivers around, the better for the child. So I have done dyadic therapy with grandfathers and mothers, with fathers who come into the program. A lot of times, I think our fathers do not get very good services, at least in our area, in terms of parent education. And so a lot of the times the moms, as they're learning about how to use some positive parenting skills, they're like, how come somebody can't teach this to her dad or whatever? So we try to involve them and help educate the dads that are available to be part of that infant's circle of security.
That's great. Thank you. And we're going to try to get a couple more questions in. So I'm going to try to go quickly and let's get brief responses from you. There was a question about the peer navigators that you mentioned in the presentation. Are these peers who have recently become mothers themselves or recently gone through pregnancy? and post themselves.
Any variety, and you don't even necessarily have to always have been a mother with lived experience to be a peer. We hire oftentimes people that have completed our program. Kind of what we say is, if you don't need us for 2 years, then we would love to have you come back and work on our team. Essence, do you want to talk a little bit about the peers that you've had at Wake?
Yes, I'm so sorry. I was actually responding to this Q&A, this QA in the box. Yes, so we have an integrated healthcare model in our Wake County program, and so we do have what we call peer support specialists who provide that emotional support and also assistance with linking to care from that perspective of that shared experience and balancing that personal, but also that the professional component of that, and recognizing that they're not there alone. And I do think it's really important to have a diverse treatment team, a multidisciplinary team, and having experts come from different backgrounds and how we identify experts in that way. And so making sure that so many people are at the table and all voices are at the table. And I really think, recovery coaches, peer support coaches, and individuals with lived experiences, whether, incarceration and addiction, is very invaluable for the work that we do. I will also say that my program is an outpatient program. So when you're thinking about community outreach, or we use the term street outreach, on the ground, meeting individuals where they are, is really important to have that, diverse team being out doing that work.
Thank you, Essence. I'm going to try to squeeze in 2 more. How do you support parents or moms who wish to continue using drugs?
Maybe Elizabeth, do you want to talk about that from your prenatal care clinic perspective?
Sure. A lot of what we do is meet frequently with moms and provide them with education and support. We want to be sure that they stay safe. So if mom is using opioids, for example, we make sure that she's got Narcan available to her. We talk about treatment options, that it really is, I love your analogy, Hendrée, about sort of being in the sidecar. We are not the drivers of the experience. We are there to be supportive. And it's being there and being supportive and being able to sort of hold space for mom wherever she is in the moment, and making her feel safe so that whatever choices she's making, we can sort of help shepherd her to the birth and then afterwards as well.
Yeah. And I think, too, it's providing that support that Nishka highlighted a few minutes ago. What support can we provide her to help her thrive to her best potential, whatever that looks like for her? And it is not us to judge or determine, it is up to her to decide what is right for her. And we have fantastic data starting from the late 60s all the way up through, I think 2019 was the most recent publication, showing that as long as people are coming to prenatal care, the chances for them to have positive, healthy birth outcomes, regardless of use, is incredibly powerful. So it's that communication and that support that matters most.
One more, and it's looking a little bit longer term. We focused a lot on mother baby, but are there experiences with longer term support to the dyad, for example, through primary school, beyond primary school years? What do we know about that from research? What does that look like?
Yeah, Yvette, do you want to talk about the older children that you've been working with?
We still have evidence-based treatments that work with older children. And child parent psychotherapy, which is one of the evidence-based interventions that I use, goes up to the age of 6. Sometimes with the older children, we see that they have had multiple adverse experiences and may be experiencing PTSD. And so we do use TFCBT, which includes some individual sessions with the older children and co-joint sessions with the caregiver to help address some of those PTSD symptoms. But attachment is lifelong. I can imagine that many in our audience have an attachment to their mother, as we've been talking about all the past hour. And I have teenagers, right? So we talk about how in infancy, that attachment relationship is a very close, tight-knit circle because the baby can't get away from us. But once they're 17 years old and can go out on their own, that circle gets much, much, much bigger. But all attachment relationships, all children come back in for support and care if they think that they can get it. And so it's just because I have some moms in our program that have older kids, they're like, is this for me, Miss Yvette? I'm like, oh, yes, it is. Oh, yes, it is. So it's a lifelong relationship that, again, as we know from research, has impact on the whole lifespan.
Great, thank you. Well, I think that's a good note to close on today. Hendrée, Yvette, Essence, Elizabeth, want to thank you for such terrific content and presentation and for bringing the idea to us and allowing us to be part of it. Leslie and Mishka, thank you so much for your expert commentary and for sharing the time with us. And and thank you to our audience. We had over 400 people on at one point this afternoon. So we are thrilled that there's this kind of interest in a focus on the mother-child dyad and on healthy families, and look forward to working with many of you in the future. Questions we did not get to, we will work with Hendrée and her team and try to address those in a follow-up document that will be on our website in a few weeks from now. Thank you all very much. We'll look forward to seeing you on our next webinar. Have a good afternoon and stay safe.
Thank you so much.
Thank you.
Bye, everybody.
Bye, thank you.
Thank you.
Thank you.